Good day, we are the Group 8. Our presentation today will focus on serous fluid. Next slide. This fluid acts as a lubricant between the membranes, allowing enclosed organs to move freely. Next slide. This images compares the parietal and visceral membranes. Parietal membranes, this membrane lines the walls of body cavities, while the visceral membranes, this membrane covers the organs within those cavities. Next slide. For hydrostatic pressure, this pressure pushes fluid into the membrane, while the oncotic pressure, this pressure reabsorbs fluid back into the capillaries. Next slide. This image just shows a slide about the specimen collection, specifically focusing on terminology related to the collection site. For thoracentesis, this involves collecting pleural fluid, which is fluid from the space around the lungs. Pericardiocentesis, this involves collecting pericardial fluid, which is fluid from the sac surrounding the heart. For paracentesis, this involves collecting peritoneal fluid, also known as ascitic fluid, which is a fluid from the abdominal cavity. Next. For EDDA, it is used for the cell count and differential test. For SPS or sterile heparinized tubes are used for microbiology tests. For plain tubes or heparin tubes, these are used for chemistry tests. Transudates and exudates. For the transudates, this is a non-inflammatory. They happen when there's a problem with the pressure inside the blood vessels. For the cause, it's usually caused by conditions like heart failure, liver problems, or hepatic cirrhosis, or kidney problems, or nephrotic syndromes. How it works, there's an imbalance between how much fluid filters out the blood vessels and how much gets reabsorbed back in. Next, for exudates, inflammatory, they happen when there's inflammation or damage to blood vessels. They are usually caused by infection or malignancy. So how it works, the walls of the blood vessels become leakier. So the fluid and proteins leak out more easily. Laboratory differentiation of the transudates and exudates. For appearance, transudates are usually clear and watery. Exudates are cloudy or bloody. Spontaneous clotting, transudates do not clot, while exudates do. Fluid serum protein ratio, transudates have a ratio less than 0.5, while the exudates have a ratio greater than 0.5. For serum LD ratio, transudates have a ratio less than 0.6, while exudates have a ratio greater than 0.6. WBC count, transudates have a WBC less than 1,000 per UL, exudates greater than 1,000 per UL. RBC count, transudates have an RBC count less than 100,000 per UL, exudates greater than 100,000 per UL. For protein, transudates have a protein level less than 3 G per DL, exudates greater than 3 G per DL. For serum ascites albumin gradient, transudates have a greater gradient greater than 1.1, exudates less than 1.1. In simple terms, this helps the doctors figure out what kind of fluid is building up in a patient's body by looking at its color, how it clots, and at the amounts of certain substances in it. This helps them diagnose the problem. Next.
Next, we have pleural fluid, which is essential for diagnosing various conditions affecting lungs and surrounding membranes. The pleural fluid is a thin, watery liquid that lubricates the space between the pleura, the membranes lining the lungs, and chest cavity. Analyzing its appearance and composition gives us vital diagnostic clues. We have pleural fluid appearances. Could be either chylous and pseudochylous pleural effusions. First appearance, we have clear pale yellow, which is considered normal. Next, we have turbid. WBC infection usually indicates a high white blood cell count, suggesting an infection. Bloody fluid or hemothorax can be due to a traumatic tap, a pulmonary embolus, tuberculosis, or malignancy or cancer. Next, we have milky. Fluid points to a chylous effusion from a thoracic duct leakage. Next, we have pseudochylous fluid. It is associated with chronic inflammation. And next is a brown fluid may suggest a ruptured amoebic liver abscess. For black fluid, characteristic of an Aspergillus infection. It is a type of a fungus. Next, lastly, is we have viscous. The fluid here is often seen in malignant mesothelioma, a type of cancer linked to asbestos exposure. Next, we have the comparison between chylous and pseudochylous pleural effusions. For the cause of chylous effusion, it is caused by thoracic duct damage, often due to a trauma or tumor. For pseudochylus, chronic inflammation like tuberculosis or rheumatoid arthritis. The thoracic duct is the main lymph vessel. Damage leaks chyle, lymph fluid containing emulsified fats. For the appearance, chylous effusion appears milky or white, and for pseudochylus, it appears milky or with green tinge. The green tinge can be related to the long-standing nature of the effusion. Next is we have leukocyte presence. For chylous effusion, it's predominantly lymphocytes, and for pseudochylus effusion, it's predominantly milky cells or mixed cells. Lymphocytes are a type of white blood cell or WBC. High counts here relate to the lymphatic origin. For cholesterol, it's absent in chylous effusion while present in pseudochylus effusion. Cholesterol accumulation is a hallmark of the long-standing nature of pseudochylus fluid. Next, we have triglycerides. Triglyceride in chylous effusion is greater than 110 milligrams per deciliter, while less than 50 in milligrams per deciliter in pseudochylus effusion. This is the most definitive test or the gold standard test for these effusions. Chyle is rich in triglycerides. And lastly, we have Sudan 3 staining. For chylous effusion, it's strongly positive, while negative or weakly positive in pseudochylus effusion. Sudan 3 is a lipid stain. It confirms the presence of a fat droplets in chylous fluid. In summary, chylous effusions are high in triglycerides from recent leakage, while pseudochylous effusions are high in cholesterol from chronic breakdown. Next is we have our tumor markers. Tumors can be measured in pleural fluid to aid in cancer diagnosis. Let's clarify the acronyms. For CEA, it stands for carcinoembryonic antigen. This marker is elevated in many cancers, including lung, breast, and gastrointestinal tumors. CA125 is associated with metastatic uterine cancer, though it's most famous as a marker for ovarian cancer. Next, CA15.3 and CA549. These are primarily used as markers for breast cancer. High levels can monitor recurrence or response to therapy. For CYFR8, 21:1 is a fragment of cytokeratin 19. It is a key marker used in the diagnosis and monitoring of lung cancer, particularly non-small cell lung carcinoma. By carefully assessing the fluid's physical appearance, lipid content, and tumor marker levels, healthcare professionals can accurately distinguish between conditions ranging from simple infection to complex malignancies, guiding appropriate patient treatment.
So next, we will be talking about the pericardial fluid, which is a thin serous fluid found in the space between the heart's outer and inner layer. So this fluid serves as a lubricant for the heart and is typically seen clear and pale yellow. So the purpose of testing this fluid is for us to diagnose conditions like infection, malignancy, hemorrhage, or inflammation in the pericardium, and the process of collecting the specimen is called pericardiocentesis. For the appearance, we have clear or pale yellow, which indicates normal, turbid, which indicates infection where there is a massive influx of white blood cells. For blood-streaked specimen, this suggests infection or malignancy due to tumor causing minor bleeding. For, for grossly bloody specimens, there, this suggests that there could be cardiac puncture or anticoagulant medications, which causes trauma or impaired clotting. And for milky specimen, it indicates chylous or pseudochylous effusion where there is a presence of high levels of fats. And next, we will be talking about the peritoneal fluid, which is a watery fluid that fills the space between the walls of the abdomen and the internal organs. Normal peritoneal fluid is typically clear and pale yellow, which serves to lubricate the surface of abdominal organs. The process of collecting this specimen is called paracentesis. Testing peritoneal fluid helps us to determine the cause of ascites, often related to liver, heart, or kidney diseases or infection. For the appearance, the normal appearance of this fluid is clear or pale yellow. When it is turbid, it indicates microbial infection. When it is green, there could be bile, gallbladder, or pancreatic disorder. And if it's blood streak, there could be trauma, infection, or malignancy. And when it is milky, there could be damage to the lymphatic system, such as trauma and blockage. Next, for the cellular examination, Less than 500 WBC per microliter is the normal range for the peritoneal fluid, which indicates that low cell count reflects the healthy peritoneal lining, and greater than 500 WBCs per microliter, which is an elevated WBC count, suggests conditions like bacterial peritonitis or complications of cirrhosis. And this ends our presentation about serous fluid. Thank you for listening.